Good evening, everyone, and welcome to the webinar on Breadth of Progress NSCLC Frontiers. It gives me great pleasure to invite our program director, Dr. Stalin Chowdary Bala, medical oncologist from Visakhapatnam, to give the opening remarks. Over to you, sir.
A very good evening, everyone. So thanks all the faculty, speakers, panelists who have joined this evening and for the Breadth of Progress NSCLC Frontiers. So the next 1 to 1.5 hours, we will have discussion on various aspects of the EGFR mutated, the overview of lung cancer and the various targets which are available to treat the advanced NSCLC. So we'll have 3 talks, 4 talks, and one panel discussion which was moderated by me. So a warm welcome to this meeting and very good evening to all of you. So without much waste of time, we'll go to the topic proper. The first topic is by Dr. Venkatesh. So he is a medical oncologist at Homi Baba Cancer Hospital, Vizag, and a good friend of mine. And he'll be talking on the overview of lung cancer. So over to Dr. Venkatesh.
Is my screen visible, sir?
Yes, yes.
Yeah. Thank you, sir. Thank you, Stalin, sir. So, good evening, everyone. So today, briefly, I'll be discussing about the overview of lung cancer. So it's a vast topic, so I'll briefly covering it so that it will be most take a revision of us. So coming to these are my disclaimers. So coming to the global data of lung cancer, incidence-wise, it's the second most common cancer, while most common cause of cancer-related deaths is the lung cancer. Globocon 2020 worldwide data. And coming to the Indian data, incidence, it is lung cancer is the fourth most common cause of cancer after breast, lip, and oral cavity and cervix cancer. And in terms of mortality, is also it's the fourth most common cause in India. So only 14% of lung cancers in India are diagnosed at early stage. So if you see here in the graph proportion, distant mets are 44% in lung in male and similarly 48% in female. But again, the right bottom, if you see the breast, which is most common, but usually it will be majority will be the early breast cancers or local regional, but distant mets are only 10% compared to 44% in the lung cancer patients. And one more, as we all know, will an early detection help to improve lung cancer survival? Definitely yes, because the 5-year survival rate, if you see, outcomes starts decreasing with increasing stage. So like 92% survive for 5-year out of the survival is stage, 92% in stage 1, but when it's only 10% in stage 4. So what are the predominant risk factors? One is smoking, which is the leading cause. It is about 9 out of 10 causes. Smoking is the most common, and also the second-hand smoking or the passive smoking. And the family history, though not so commonly we see, but still there is incidence. First degree relatives having the family history, and exposure to radon gas, asbestos, or other pollutants and radiations are the other predominant causes. So coming to the brief approach in the diagnosis. So the initial presentation usually will be either a screening finding or an incidental finding, primary care physician diagnosing, or patient coming in an advanced stage with an emergency situation. So coming to the clinical and laboratory evaluation, which is mostly the history, medical history, comorbidities based in blood tests like complete blood picture, renal tests, liver tests, and bone parameters. And imaging, chest X-ray, chest CT. These are the common things which will be done routinely, which are the predominant upfront diagnostic images. And then when they come to an oncologist or then later of the diagnosis, we can go for PET CT and MRI brain for them. Then coming to the pathology, which is a tissue procurement, which is challenging in some cases. That it can be either done by bronchoscopy or EBUS or CT guided biopsy, sputum cytology, or thoracocentesis and media stenoscopy. And the tissue testing for histology and molecular testing. Then finally, the clinical diagnosis and staging. So the images that are used to look for the tumors in the lung. So imaging predominantly used in initial diagnosis, as we discussed, chest X-ray and CT, which are the predominant mode, and then PET and PET CT. And additional imaging workup, which is MRI brain and bone scan also. If PET is not done, bone scan also. So sampling techniques. So the choice of tissue sampling technique is guided by the location of tumor within the lung, and poor choice of sampling method can result in insufficient tissue. Just not knowing the histology, but we need to know the molecular testing also. So that is also equally important. So for initial sampling is sputum sample or bronchoscopy, needle biopsy, or thoracocentesis, or EBUS guided or US aspiration, media stenoscopy, or thoracoscopy or thoracotomy can be tried. And with the resectable disease may have additional tissue for analysis following surgical resection of the tumor. But in case of not feasible, if it is an inaccessible site or it is not feasible for a tissue biopsy, then if patient has an inaccessible site or lacks of sufficient tissue, then liquid biopsy is typically used to complement tissue biopsy, and both techniques may be employed in parallel to maximize the efficacy of diagnostic pathway. So types of staging, as we know, clinical staging and pathological staging. Clinical is based on all preoperative diagnostic workup, including clinical imaging and pathological analysis, which determines the tumor size, position, regional nodal status, and presence of distant mets. And it allows the MDTT, multidisciplinary team, to plan the initial treatment approach, including surgical technique if feasible, use of neoadjuvant or adjuvant therapy. And pathological staging is based on surgical resected tumor specimen and determines all staging parameters based on surgical finding, and also it gives a pathway for adjuvant treatment approach. So briefly about the TNM staging. So T1, it's about below 3 centimeters, and T2 more than 3 to 5 centimeters, or involving visceral broncha, visceral pleura or main bronchus, not up to carina, and atelectasis to hilum. And T3 is more than 5 to less than 7 centimeters, or involving chest wall, pericardium, phrenic nerve, or tumor nodules in the same lobe. And T4 is more than 7 centimeters, or involving the mediastinum, diaphragm, great vessels, recurrent laryngeal nerve, carina, trachea, esophagus, and spine, or tumor nodules in the different ipsilateral lobe. Coming to briefly N staging, N0 no nodal stage, N1 ipsilateral pulmonary or hilar, N2 is mediastinal ipsilateral or subcarinal, N3 is contralateral mediastinal or hilar or supraclavicular nodes. And M0 is no distant mets, M1A is malignant pleural or pericardial effusion or separate tumor nodules in the contralateral lobe, M1B is single extrathoracic mets, and M1C is multiple extrathoracic mets. And briefly, lung cancer, we all know it is either broadly divided predominantly to 85% non-small cell lung cancer, about 10 to 15% small cell. Small cell, also known as Ward cell or small cell undifferentiated carcinoma. And coming to non-small cell, about 20 to 35% is about 30% is squamous, and other non-squamous are adenocarcinoma, which is 40%, large cell about 10 to 15%, and other miscellaneous types. So treatment is decided whether it's small cell or non-small cell predominantly. Come to briefly about small cell, as we all know, it is about 15%, and overall survival less than 1 year. It's about overall about 7.2 to 11.4 months, which is the data from Delhi AIMS and ADR Chennai. And with the advance of treatment, the small cell predominantly earlier days it's only used to be a chemotherapy based, which is cisplatin or carboplatin with etoposide. And in the relapse and in a limited disease or advanced disease, it's broadly divided into two. And in limited disease, radiation has come later. And later in the relapse setting, topotecan has come in the early 2000s, and PCA. So prophylactic for limited disease with good control of the early chemotherapy. So prophylactic cranial radiation can be given. So come later in the relapse setting, oral topotecan is tried. And presently with immunotherapy is the latest thing with carboplatin, cisplatin or carboplatin with etoposide and durvalumab, the latest immunotherapy based regimens in the small cell setting. And come to non-small cell, it is predominantly histology based subtype of squamous or adenocarcinoma. And in adenocarcinoma, if you see the molecular pattern, predominantly which is unknown, and of the known things, it is EGFR and KRAS are the predominant mutations. And coming to squamous cell, predominant unknown, and of the known things, FGFR1 amplification and few EGFR are the predominant mutations we see in non-small cell adeno and squamous cell types. So what are the advances in treatment of NSCLC early stage and late stage? So as we all know, apart from chemotherapy, present era is full of targeted and immunotherapy. Significant increase in approvals to targeted as well as immunotherapy in non-small cell has seen. Like early phases we got for ALK-positive crizotinib, then EGFR, erlotinib, geftinib, crizotinib again. And even for MET-retin mutations, we got capmetinib, selpercatinib, and we got in early 2018 something like that osimertinib for the EGFR positive, which is third generation, and NTRK and ALK positive. So these are the various improvements in the targeted agents, and similarly to the immunotherapy also, the checkpoint inhibitors, PD-L1 inhibitors, dual checkpoint inhibitors. So combinations of immunotherapy, checkpoint inhibitors are also in the progression. So as we all know, multidisciplinary team management with a pulmonologist, radiologist, pathologist, medical oncologist, and cardiothoracic surgeon. So early stage, predominantly goal of the treatment is cure, where it is a surgery. When the disease is limited to lung and not involving mediastinum is stage 1 or 2. And when the disease involving mediastinal node, it is a stage 3 disease. And treatment is predominantly surgical resection for early stage disease, either lobectomy, pneumonectomy, wedge resection, or segmentectomy for patients with limited reserve. Then outcome surgery is the primary treatment, and adjuvant cisplatin-based therapy is recommended for stage 2 and 3, as we all know with the latest data, with the OS hazard ratio of 0.89 and 5-year DFS hazard ratio of 0.84. But overall disease recurrence and death following surgery and adjuvant chemotherapy remain high across the disease stages. And unresectable stage 3, when mediastinal node is involved, unresectable, though the predominant approach will be the cure, it will be the concurrent chemoradiation predominantly better than sequential chemoradiation. So definitive chemoradiation is a standard of care for stage 3 unresectable NSCLC. So come to stage 4, as we all know, majority will be stage 4 diseases, and treatment goals will be extended survival and maintain and improve quality of life. So it will be either chemotherapy based on the molecular driven or targeted therapy or checkpoint PDL1 based on PDL1 status. In the targeted therapy, predominantly EGFR all cross, which we have the predominant. And the survival rate is with the EGFR positive targeted therapy survival rate 8 to 12 months. With the FLORA data, we have 38 months of positive data, and for the immunotherapy keynote 24, 30 months in PDL1 more than 50%. And the targeted therapy EGFR FLORA Osimertinib 38 months. So what is targeted therapy? Precisely identify the particular cancer target, attacks or inhibits the target, stops cancer cells or growth or kills cells. And by molecular testing, we can identify the test, and 50% of lung cancer can have some targetable mutations. And immunotherapy enabling body own immune system to fight the cancer. So this is a brief mechanism of PDL1 or PDL1 inhibitors. So to summarize, the overall 5-year survival in NSCLC is between 10 to 15%, because primarily majority of patients will be either locally advanced or distant metastasis. Also, as I just 30 to 60% of NSCLC patients undergoing surgery eventually develop metastatic disease. So we need to have there's a need to improve neoadjuvant or adjuvant options in order to improve the outcomes. And adjuvant osimertinib will provide a highly effective practice changing the present data we have stage 1B or 2 and 3 EGFR as an adjuvant setting as for completion of tumor resection. So largest unmet needs are improving lung cancer literacy and awareness, increasing access to most innovative medicines, evolving how we think about patient support to increase survivorship, and enabling early diagnosis of lung cancer. So general physicians, the partner in the management of lung cancer, who the patient approach first rather than an oncologist predominantly. High index of suspicion for early and prompt diagnosis, optimal referral to the oncologist, brief patient about the importance of various tests, and take care during complications and follow up and recurrences. So thank you. Thank you, sir. Thank you, Stalin, sir, and thank you, AstraZeneca.
Thank you, Dr. Venkatesh, for such a lucid talk and giving an overview of so the lung cancer and briefly how we manage the lung cancer. Thanks and many thanks for sticking on to the time. So we now move on to the second talk by Dr. Venkata Simha, medical oncologist from Hyderabad. So on defining targets in metastatic NSCLC, how relevant is liquid and tissue biopsy in clinical practice? So over to you, Dr. Venkata Simha. Dr. Venkata Simha, are you there?
So you will have to unmute yourself. Yes, sir.
Hello. Is Venkata Simha there?
Yes, sir. Sir has unmuted himself. Unfortunately, we are unable to hear him.
Okay.
So till that time, we can move on to the next speaker talk, sir.
Yeah, sure. Is if Dr. Kripa says okay, we move on to the next talk. Meanwhile, Dr. Kripa.
Hello.
Dr. Kripa. Venkata Simha, are you there?
Yeah. Are you audible?
Yeah, you are audible. You can go ahead. You can go ahead with your talk on defining targets in metastatic NSCLC. How relevant is liquid and tissue biopsy? Go ahead. You are audible.
Yeah. Okay. So can you please share the slides? Hello.
So we haven't received your slides, sir.
Have shared it to somebody, no?
Sir, we haven't received your slides yet.
I think you can move on to the next topic after
next
that.
talk. Meanwhile, you can share the slides. Dr. Kripa, are you ready? Hello, Dr. Kripa. Hello.
Yes, I'll just try calling ma'am.
Hello.
Yeah,
Hello.
Himanshi is contacting Dr. Kripa for.
I think I shared the slides. Can you open?
Himanshi, did you receive the slides?
Yes, sir, I'll just play it, sir.
Then Dr. Venkata Simha, you can go ahead with your talk. Meanwhile, Himanshi, please contact Dr. Kripa to be ready for the next session.
Okay, sir.
Can you say this is Dr. Venkata Simha, so senior consultant medical oncologist from Chennamaneni, LB Nagar. So at the outside, I want to thank AstraZeneca people and Dr. Stalin sir for giving this opportunity. So the slides are provided by AstraZeneca and modified by me. Next slide. Hello. Yeah. So
You are audible. Go ahead.
Yeah, as you all know, you see the management of lung cancer is now totally changed with the advent of biomarker targeted therapies. So NSCLC is not one disease. So previously we have histologically what classification squamous, non-squamous, that is adenocarcinoma. Now the adenocarcinoma, again the biomarker mutations wise, we have a number of diseases like EGFR, ALK, and RAS, MET, RET, so NTRK, HER2 positive, and KRAS mutations. So next slide, please. So the need of biomarker testing in advanced has accelerated in recent years with the advent of targeted and immunotherapies. So for each one, say EGFR positive, we have set of agents, and even for ALK, we have another set of agents. And this is the cartoon showing the evolution of all these mutation markers and also the simultaneous the agents which act on these markers, that is targeted therapy. Next slide, please. See, this is the guideline showing about what test we have to order. So basically, so if at all NSCLC is there, means in early stages, we just go for only EGFR, ALK, and PD-L1 in resectable lung cancer, that is from stage 1B to stage 3. So now in metastatic, that is a recent advancement. That is in metastatic setting, we'll go for molecular testing like EGFR, ALK, RAS, BRAF, MET, RET in case of adenocarcinomas. Even in squamous cell carcinomas, we'll able to we can consider for all these mutation analysis. Next slide, please. So this is a diagram showing what test I told in the previous thing only. The resectable cancers, recent advances because of perioperative immunotherapy, and we have neoadjuvant or adjuvant immunotherapy. We EGFR and all PD-L1 status we will see in the non-metastatic setting. So whereas in metastatic setting, as you people all know, that EGFR, ALK, RAS, So these are the Cat 1 recommendations according to the NCCN, and remaining also we have to do as a category 2A recommendations. Even in squamous cell carcinomas also we have to do these tests. And next thing is that how to test, say, tissue specimen, preoperative biopsy or surgical resection sample, or we can go with diagnostic biopsy. The other one is the liquid biopsy. So liquid biopsy, when we consider if the tissue is insufficient or unavailable, so, and we have to consider this liquid biopsy, which is complementary to the tissue biopsy. So we have to do in concurrent wise so that we can able to see more biomarkers, and the sensitivity of the entire biomarker panel is increased with when we combine both the complementary and when we combine both tissue biopsy and liquid biopsy. Next slide, please. See, this is a picture showing when we go for biomarker testings and we compare the survival between the patients who undergone this biomarker testing and further biomarker targeted therapy. So there is a difference between of minimum of 10-12 months of in the survival rates. So it is in without marker testing, it is of 6 months, and with marker testing, it's of 18 months. Next slide, please. So these are the main reasons for the failure to obtain a molecular diagnosis is basically the tumor cells what we obtained in the tissue biopsy is inadequate. And at the same time, there is insufficient tumor cells in the tissue biopsy sample, and the quality of the tissue biopsy sample is also inadequate. These are the main two reasons, because we cannot able to access the site. And if you access the site also, the tumor tissue, tumor cells present in the tissue biopsy is also very less, and the quality of the tissue sample is also less. And for repeating the biopsies also is very difficult, as it is an invasive test. So next slide, please. So this is a picture showing, I told tissue quality and quantity is the main issue with the tissue biopsy. So there is actually among the patients, there is a 7 to 20% can't undergo molecular testing due to this insufficient tissue or insufficient tumor cell content even after obtaining the tissue biopsy. So, and before the biopsy, also 20% of the patients cannot undergo biopsy, maybe because of various reasons, and some 3% of the patients refuse to undergo tissue biopsy. Next slide, please. So, and here the liquid biopsy consists of obtaining the circular tumor DNA from plasma, which provides a source of clinically actionable molecular informations. So it can detect DNA-based mutations. Basically, non-DNA-based mutations can't identify the circulated tumor DNA liquid biopsy. So like deletions, insertions, point mutations, amplifications, translocations, and chromosomal aberrations. All these can be detected by the liquid biopsy with the ctDNA. And the ctDNA we can subject to either PCR-based test or NGS-based test. So next slide, please. So that thing only. So real-time PCR, we can, as you know, PCR versus NGS, single gene panel. PCR is basically a single gene panel, and NGS basically multi-gene panel. We can simultaneously assess multiple genes, genetic alterations. So regarding that, limits of detection also, if it is for real-time PCR, it is 1 to 5%. Whereas in case of digital PCR, it is 0.1 to 1%. With the NGS, it is of 0.01% to 5%. Next slide, please. See, in patients with metastatic NSCLC tested by liquid biopsy assay at initial diagnosis, so the liquid biopsy is having a specificity of 100%, whereas sensitivity is of 70 to 80%. So which means that, so if at all, if patient underwent a liquid biopsy, if the test is positive, the PAS2 driver gene mutation, we can, along with tissue biopsy, we can move on to the treatment. When the test is negative, because it is a less sensitive test, we have to order again with tissue biopsy. So this is the main thing. So it is more specific and the sensitivity is somewhat low. So whenever the test is negative, we have to definitely we have to proceed with tissue biopsy. Then next slide, please. So these are the various methods how we obtain the tissue biopsy. So as I already told, the liquid biopsy we cannot use in case of early stage non-metastatic NSCLC, because in the coming slides, I can tell you the concordance rates and the sensitivity is very less in early stages with liquid biopsy, whereas in metastatic setting, we have to use this liquid biopsy. So next slide, please. See, patients with resectable or have told already. This one, liquid biopsy, whereas in metastatic NSCLC, along with the tissue biopsy, we can go for liquid biopsy in order to increase the biomarker detection rate. And then also we can subject the patients to targeted therapy so that the patient will get benefited. Next slide, please. Here the picture showing the high concordant rates between the liquid biopsy ctDNA sample and tissue-based sample for detecting the biomarker mutations. So one is the sensitivity, if you observe, so overall concordance across all 4 genes for EGFR, exon 19 deletion, EGFR, L858R, or ALK fusion and RAS and BRAF. There is a all 4 genes, the sensitivity for with a concordance rates with liquid biopsy is more than 98.2% with a positive predictive value of 100%. Next slide, please. So this is the thing. So appropriate treatment choices for the patients with metastatic can be guided by tissue or liquid-based testing. So whatever may be the assessment mode of assessment, there is the results will be evident clinically. So that if at all in patients with inadequate tissue sampling or inaccessible sites, we can consider the liquid biopsy. If the liquid biopsy turns out to be shown any positive mutations, we can proceed with the treatment, and after that the results will be very good. Like that only, if at all, if you combine both the liquid biopsy and tissue biopsy also, still more the sensitivity is increased for detection of these mutation markers, so that we can subject it to targeted therapy rather than the liquid biopsy alone. Next slide, please. So this is the turnover time comparison between the liquid biopsy and the tissue biopsy sample. When we subject the tissue biopsy sample for NGS, it will take almost around 20 days. Whereas if you subject to liquid NGS, means liquid biopsy ctDNA sample for NGS, it is almost 9 days. When you compare the same thing with the PCR, it is of 12 days and 3 days. So the turnover time is greatly reduced with liquid biopsy. Next slide, please. Here the resection, so basically if you proceed with the tissue first, we can able to detect the this biomarker mutation, targeted mutations in 60% of patients when you proceed only with tissue biopsy. So when you go for liquid biopsy as the first one, there is an increase in the sensitivity because the tumor heterogeneity and the picking up of the mutation markers is somewhat higher in case of liquid biopsy. It will increase to 77%. When we combine both the tissue and liquid biopsy, that is actually recommended. So even in guidelines, that is both are complementary, and it will increase again the detection rate to 89%. So that more number of patients we can subject it to targeted therapy so that they can get benefited by overall survival. Next slide, please. So So this is the main thing. The rationale of integrating the liquid biopsy into the routine management of metastatic NSCLC. So liquid biopsy may be useful in with patients with difficulties in undergoing a biopsy due to the patient's suboptimal clinical. So PS is very low. We cannot do the invasive test, or unfavorable tumor site where we cannot do the tissue biopsy. So liquid biopsy also may overcome the issues of scarce tumor tissue in the tumor biopsy what we isolated. And liquid biopsies may spare the patients from additional invasive procedures. If you want to repeat the sample also, it is very rebiopsy by liquid biopsy is very feasible rather than this tissue biopsies, where the rebiopsy is almost impossible. So liquid biopsy typically supports faster molecular analysis, I told. So these are the 3-4 important advantages for the liquid biopsy. We can increase the sensitivity by combining both the two, and at the same time we can able to detect more and more markers by combining with the liquid biopsy, and we can get the results at a very shorter turnover time. And even in the inaccessible sites also, it is a very important, it plays a very important role. And when the tissue samples are also inadequate, also for repeating the rebiopsy is also very much feasible in case of liquid biopsy. Then next slide, please. So this is what I told already. So when we subject any patient in upfront NSCLC with liquid biopsy and combined with tissue biopsy, or with only liquid biopsy also. So in case of poor performance status and where we cannot access the tissue biopsy, so in those type of cases, when we start with liquid biopsy also, so when any biomarker mutations, if we isolate and if you start the treatment based upon that result also, if you after 3 to 4 months when we reassess also, there will be a good response with the biomarker targeted therapy. So this also proven clinically. So this cartoon representing the same thing only. Next slide, please. So each one, the tissue biopsy is having own advantages and disadvantages. Where the advantage of tissue biopsy means basically we can assess the histological classification as a squamous or non-squamous, and we can go for PD-L1 testing. This is and the sensitivity is somewhat more in case of tissue biopsy, whereas in liquid biopsy, as I told, whenever the inadequate tissue sample is there and we cannot access and we cannot perform the test only in those type of cases for shorter turnover time, and we can get more number of markers we cannot miss any tumor heterogeneity means the liquid biopsy is a very best things. So when we combine both the things, the benefit is still more for the patients for overall improvement in the overall survival. Then next, please. So this is the same thing only. When we present both with tissue plus liquid concurrently, or tissue only, or with liquid only, based upon the variables of how much actionable driver mutations we can able to detect, and turnover time and cost of the testing. The other disadvantages with the liquid biopsy is the cost of the testing is also somewhat more. Next slide, please. So because as I told in the previously slides also, the non-metastatic setting in NSCLC is basically from stage 1 to 3. So subjecting the patients to liquid biopsy is not a good idea. Why? Because the sensitivity is very low and the burden of the circulating tumor DNA is also very low, and the concordance rates also is very low. So the stage wise, this is the percentage of concordance rates: 12.4%, 58.3, and 55.6 in stage 1, stage 2, stage 3 respectively. Whereas in metastatic setting, it is almost going to up to 73.8%. So that's why the liquid biopsy is not at all feasible as a sample to assess the EGFR ALK or PD-L1 status in a resectable non-metastatic NSCLC, but only in metastatic setting only the liquid biopsies plays an important role. Next slide, please. So this is the same thing what I told. So all the guidelines are also representing the same. We have to combine the tissue biopsy and the liquid biopsy. So on the negative test, when you going with the liquid biopsy test and the test is negative, means we have to definitely subject that patient to the tissue biopsy again. So next slide, please. So this is the same thing only, the previous one, but I told clearly. So when we start with liquid biopsy or when we start with the tissue biopsy, and what are the advantages between the tissue when you combine both the tissue and liquid biopsy at upfront setting. Next slide. So at a glance, I just want to tell this thing, the advantages and disadvantages of tissue biopsy versus liquid biopsy. So as I already told, the advantages of pathological, say histopathological classification we can do with tissue biopsy and assessment of DNA and non-DNA biomarkers. Why? Because circulated tumor DNA. So only DNA markers we can able to mark our genetic DNA based genetic alterations only we can see with liquid biopsy, whereas non-DNA based biomarker alterations also we can see in case of tissue biopsy and PD-L1 assessment. So these can be we can do with tissue biopsy, whereas with liquid biopsy we cannot do this. So disadvantages is that longer turnover time, limited tissue quantities, and as it is an invasive test, at progression rebiopsies is very difficult, and tumor heterogeneity. So whereas the liquid biopsy is having advantages like rapid turnover time, highly concordance rate, minimally invasive, repeatable over time, better capture tumor heterogeneity and clonal evolution. The disadvantages, what I told earlier, is somewhat costly. Negative test means we have to confirm again with the tissue biopsy, and non-DNA biomarkers we cannot evaluate, and tissue histological classification is not possible, and PD-L1 testing is also not possible. Next. So even ESMO or even NCCN also recommended that upfront metastatic setting, it is always to go for a combination of tissue biopsy plus liquid biopsy in order to get more and more actionable mutations to be detected from the patient, so that patient can get benefited with targeted therapy. Next slide, please. Next slide. Next slide. Yeah, next slide. So this is the take home message is that, so all the patients, it is always our responsibility as a treating physicians to counsel them for proper tissue biopsy, and also the same thing for liquid biopsy also. Most of the times now we are following only the tissue biopsy at upfront setting, and liquid biopsy whenever the patient is having poor general condition or inaccessible sites, and whenever the tissue is failed, then only we are going to go for liquid biopsy. But now that dictum has changed. Upfront only, even the tissue biopsy is also available. We have to go for liquid biopsy in case of metastatic setting. Why? Because we can able to detect more number of markers, actionable mutations, so that we can subject the patient to targeted therapy, so that patient can get benefit by this targeted therapy. So that's all. Thank you.
Yeah, thank you, Dr. Venkata Simha, for such an extensive talk on the liquid biopsy and the tissue biopsy. So we'll discuss some points during the panel discussion. I don't waste much time because we are behind the schedule. So now we move on to the third lecture. So managing EGFR mutated NSCLC in today's clinical practice. So the talk will be delivered by Dr. Kripa Bajaj, medical oncologist from Hyderabad. So over to you, Dr. Kripa.
First of all, I would like to thank organizer for this opportunity, and I request team to share the slides. So how are we managing the EGFR mutated NSCLC in today's clinical practice? So this is my topic of discussion. No need to say in this segment, Osimertinib is a clear winner, but how we are amalgamating the evidence into the practice is a discussion. Next slide. So what is epidemiology? As already my previous speaker mentioned, so it's a NSCLC is the most common type of lung cancer. And lung cancer, we all knew it's almost constitutes 5.5% as per the Globocon 2020 data. So in India, it's the fourth leading cause of cancer-related death in India and fourth overall incidence again. Next slide. So if you see like the stage-wise presentations, so stage 4, most of us like usually see stage 4 lung cancers. By the time they come to us, very few people are like log into stage 1. And stage 3, yes, we do see still like up to 30%. So the 5-year overall survival outcomes decrease as there is an increase in the stage as expected. Next slide. So more than 50% of stage 4 cancers, NSCLC have biomarkers. So most of the biomarkers, like previously they discussed, like both solid and liquid, they complement each other to detect the more biomarkers. So previously, some solid like NGS, like whenever it got missed, so we used to send liquid biopsy, and there is a positivity is there. Now more evidence is coming up that liquid biopsy is going to become gold standard in future, because as cancer is heterogeneous, it may shed out the cells with a different gene pattern. So, in future, we may practice that as well. So, as discussed by the previous speaker, Dr. Vijay Simha, so EGFR mutation driver is the most common one in the lung cancer. So 25%, most of the time, this is a prognostic for us. In second line, we may use it, but in the first line, it's a prognostic that all EGFR mutations may not really score well. P53 as well as KRAS existence may be prognostic to say that these cancers may not really do as long enough as regular EGFR mutations without any co-concomitant mutations. So ALK is the next one, constitutes 8% of the mutations. So KRAS, EGFR, ALK rearrangement, these three constitutes the most common. KRAS first line along with the EGFR, it's only we say it's a prognostic. But second line, sometimes if EGFR is not existing, we may use it sotorasib, but not really along with EGFR. Next slide. So testing methodology for target mutations in lung adenocarcinoma, all of us like standardize our practice to NGS, snapshot, or broad panel as per the affordability. Along with it, PDL we are sending. I hope all of us are practicing the same across the country. Next slide. The IHC in ALK, like only some people do send for a short CAT, but when patients are really having brain mets and patients are non-smokers, in that segment, like for short CAT, they are sending. Otherwise, most of us sending for NGS. So EGFR driver mutations lung cancer, the most frequent EGFR TK sensitizing mutations occur in exon 19 and 21. 20, like we do see sometimes upfront or like post-treatment, we do see exon 20 mutations or insertions. So these are the exon 18, exon 19, exon 21. These three are the most common mutations what do see, but 1921 constitutes are by and large 80%. Next slide. So based on the limited number of studies, the prevalence of EGFR mutations appears broadly similar across disease stages. So across stage 1, stage 2, like if you see, it is like almost similar incidence got noted. Overall estimated percentage prevalence is 30 to 40%. In Caucasians, 10 to 20%. If EGFR TKs were available in the resectable setting, a similar proportion of patients may be able to benefit compared to the advanced setting. And in Indian data, there is South Indian data got published, up to 60% of positivity of EGFR is there in South Indian data who are non-smokers. Next slide. So these are the NCCN guidelines already Dr. Simha told. So the responsiveness to EGFR, oral EGFR TKI is the most recent to indicate that tumors that do not harbor a sensitizing EGFR mutation should not be treated with EGFR TKI in any line of treatment, as all of us do practice the same. Molecular testing should be performed when adjuvant TKI therapy is considered from 1B to 3A. That's the ADAURA trial data. These two got highlighted, and we early stage lung cancer, this is going to get discussed. Next slide. So the EGFR activity mutations result in constant signaling by the EGFR. So there'll be a auto signaling will be there. So that itself is a self-sustaining signal, which will stimulate the cancer cell with the upregulation of the down pathways. So this is how the EGFR mutated cancer cell, if you see the right side versus the wild type. So the pathway is continuously activated because of the mutations hampered by the EGFR receptors. Next slide. So what are the current options available for the advanced lung cancer? So ROS, we know first-line crizotinib we are using. Alfusion, no need to say, alectinib and lorlatinib and ceritinib. These are the options we have. EGFR mutations, one second. I just have important call. In patients who are not having any mutations, then the PD-L1 do pitch in. So if there is a coexistent PD-L1 high, we are actually treating only driver mutations because all of us know that's driving the cancer cell in non-squamous. In squamous also, there is a EGFR mutation positivity rate is there up to 10% as per TMH study. But by and large, squamous cell, most of the times we do treat based on the PD-L1. The PD-L1 will be the guiding factor for the whole regimen management. Next slide. Next slide, please. Yeah. So Osimertinib is a third generation irreversible CNS active EGFR TK. It's selective for both EGFR mutated and EGFR T790M resistance mutation. So no need to say, as the generations of drugs are cars, just like that, it goes on, the selectivity and specificity do increase. Just like that, osimertinib is a drug which is more potent and it's able to percolate through the CNS barrier. So it's a most potent TK out of all. There is an inhibition of EGFR mutation, inhibition of T790M, and lower activity of wild type EGFR also got noted. It crosses the intact blood-brain barrier as seen in the preclinical models, which is most important because EGFR positive patients do lodge brain mets eventually, and osimertinib has a very good CNS progression-free survival and CNS disease-free survival as well in patients who are not lodging baseline brain metastasis. Next slide. So FLORA study and FLORA2 study, these were the most important studies which got recent publication. The FLORA2, just like the TMH JEF plus chemo study, it has shown the very good PFS benefit. I hope that will eventually convert to very good OS benefit like the recent data of JEF plus chemotherapy. Coming to the FLORA study, which changed the management and the metastatic NSCLC with an excellent p-value and hazard ratio. It's a randomized double-blind phase 3 study to assess the safety and efficacy of osimertinib versus standard of care EGFR TK, that's gefitinib, as a first-line treatment in patients with locally advanced or metastatic EGFR mutated lung cancer. Next slide. So, as discussed before, in this one, exon 19, L858, no prior systemic anti-cancer or EGFR TK therapy, stable CNS metastasis got allowed, maybe which got treated prior with the radiation, it's also got included. So the stratification is based on the exon 19 versus 21 and the race. So osimertinib versus gefitinib and erlotinib, this is a comparison. That's the first generation TKI. So the primary endpoint and secondary endpoint, the primary endpoint is the PFS as expected, and secondary endpoint objective response rate, duration of response, and everything, OS. So when patient got progress on the first generation TK, there's a crossover which got allowed if the patient is having T790 mutation post progression on first generation TK. Next slide. So if you see, the baseline characteristics are very well balanced across both treatment arms. Next slide. The primary endpoint PFS, if you see 18.9 months versus 10.2 months, the hazard ratio is 0.42. So the osimertinib reduces the risk of progression or death by 54% compared to standard EGFR TKI. Next slide. So the PFS is valid across all the groups like sex, age, race, smoking history, CNS metastasis, performance status, and beta any mutation, and EGFR mutation positive by ctDNA as well. The consistent benefit across all the subgroups got noted for the PFS. Next slide. The objective response rate, if you see here, the duration of response is 17.2 months versus 8.5 months. And the objective response rate, if you see, the odds ratio is like 1.28. So the response is like sustained, and a very good response rate got noted with a p-value of 0.23. Next slide. So ORR is like not as expected. It's not really scoring really well compared to the first generation, but the duration of response, if you see, it got scored really well. And again, the OS, if you see, there is a meaningful OS with 38.6 months versus 31.8 months, and with hazard ratio of 0.799, and it's a statistically significant one. Next slide. So the adverse event compared to the first generation TK, Osimertinib did not have significant side effects. It's almost comparable side effects got noted. Next slide. The safety analysis, as expected, the tolerability is really well for Osimertinib, really not significant. Any no grade 3 side effects got noted. Next slide. The FLORA study summary, it became a new standard. It was quite a discussion, and it became a new standard of care for first-line treatment in patients with EGFR mutated advanced NSCLC, and with a highly statistically significant PFS, good CNS PFS, as well as promising overall survival results. And there is a comparable safety profile is there for Osimertinib compared to first generation TKI. Next slide. The CNS efficacy, as expected, as discussed before, Osimertinib is a very good drug with a very good CNS penetration. Quickly, we'll go through the slides. Next slide. The CNS mets is higher among those harboring EGFR mutations compared to the wild type, and also ALK positivity. Also, there is a higher CNS mets are there. In this one, we will go through the slide initial diagnosis and follow-up. What is the frequency of CNS mets in patients with EGFR mutations versus wild type? If you see at initial diagnosis, 24% versus 13%, the higher level, and during follow-up, 44% versus 22%. If you say it's nearly double. The leptomeningeal mets are also very high. It's highest with EGFR mutated one. Next slide. This is the CNS PFS curves. It was consistent benefit with or without CNS metastasis, with a few CNS progression events in the Osimertinib group. That's 6% versus 15%. So if you see at the baseline with CNS metastasis versus without CNS metastasis, the hazard ratio is like very good. That's 0.47. So with CNS mets, 15.2 versus 9.6. Without, it is 19.1 versus 10.9. Means the patient who are not having CNS metastasis baseline, they may have a CNS metastasis-free survival for long time. That's a DFS for long time. If we introduce Osimertinib at the baseline, and we all know that patients who have a CNS metastasis, the quality of life is going to be poor, and we have to deal with a lot. Next slide. So the CNS activity 50, the hazard ratio is 0.48, and the CNS PFS in full analysis that is significant. Next slide. Osimertinib versus Dacometinib. So always like we do engage in discussions of Pfizer, like how comparable is Osimertinib versus Dacometinib. So Dacometinib, if you see these are the cross-trial comparison, the Archie data versus FLORA trial. The PFS, if you see, it is 14.2 versus 9.2 months. At 6 months, the curve starts separated. But here, in FLORA, the immediate separation got started, which shows its efficacy. And 18.9 versus 10.2 versus here, there's a cross-trial, there's a 4 months difference is there. But if you see the curves, there is an immediate separation of patients in FLORA trial. Next slide. The OS is again not statistically significant, since the formal comparison of oral response rate was not statistically significant on the study's hierarchical testing, and there is some flaws in the Archer study regarding the hierarchical testing. Next slide. FLORA is the first time an EGFR TK has translated PFS to a significant OS benefit. Next slide. So there is an early and sustained survival benefit shown by clear separation of curves with 3 months 1 second. With 3 months survival benefit. 1 second. With 3 months and maintained throughout the follow-up. So 54% of patients were alive at 3 years. So the OS is 30.6 versus 31.2 months with a hazard ratio of 0.79. Next slide. So in Archer, p-value could not be given to OS because of the trial had a hierarchical statistical stratified design, and given that did not meet significance in overall response rates. Next slide. So Osimertinib versus Afatinib, the second generation TKI. Next slide. The Lux-Lung study, Lux-Lung 7 PFS of Afatinib. Osimertinib has a median PFS of 18.9 months, and there was insufficient events to determine OS of Afatinib at the time of analysis. Next slide. Next slide. So the co-primary endpoint OS advantages. So the co-primary endpoint survival advantage not seen, that is 27.9 versus 24.5 months. So if you see the Afatinib versus Gefitinib, the co-primary endpoint was not met. Next slide. So Lux-Lung 7 OS were pre-specified subgroups of interest, exon 19 deletion and L858R showed similar OS trends. So Afatinib compared to Gefitinib, it's not scored really well. The hazard ratios are 0.8 and 0.91. Next slide. Osimertinib safety profile, if you see, Afatinib and Dacomitinib, there is a significant side effects got noted. The grade 3 is also significant in the Dacomitinib trial. But Osimertinib, the side effects are not profound, and there is a comparable to first generation TKI. Next slide. The first line Osimertinib had a better results compared to sequencing strategies. So we always want to introduce Osimertinib as early as possible. There is no dilemma of sequencing for EGFR mutated lung cancer by FLORA study. Next slide. So second line treatment eligible for all, predicting T790 mutations. Not all patients will lodge T790 mutations. So the best benefit is to introduce Osimertinib as early as possible. To remember that the FLORA study, there is a crossover is there in patients is having the T790 mutations. So for sequencing, there's an ideal example. So though patient lodge T790M eventually, and the percentage is very less. In spite of that, if you introduce Osimertinib in the second line, the outcome is not as great as the people who received it the first line. Next slide. So, and we can't predict who will develop T790M resistance, hence important to start with drug with greater benefit compared to other TKI. Next slide. So use of Osimertinib as second line therapy in FLORA was consistent with expected in clinical practice. So in second line, 47% of patients in comparator arm who did receive second line Osimertinib, it consistent with expected rate of T790 mutation. In total, 31% of all patients in the comparator arm received Osimertinib as a second line. Next slide. Next slide. So compared to first line, there is no need to say second line Osimertinib is like quite inferior. So better to prefer Osimertinib the first line to have a better PFS as well as OS benefit. Next slide. New therapies. Next slide. So FLORA 2 already mentioned. So it's better to combine Osimertinib with chemotherapy if patient is fit enough. So needless to mention how successful is only with first generation TK and TMS study. So definitely this is going to be a very promising result. With the longer follow-up, we will be able to establish how much OS benefit we to reap with the combination of Osimertinib and chemotherapy. Next slide. Again, the baseline characteristics are similar. Next slide. There is a PFS which got published recently. There is a good PFS benefit got noted with a p-value very significant and hazard ratio 0.62. That's 25.5 versus 16.7. Next slide. And as per BSR also, it is 29.4 versus 19.9 with hazard ratio 0.62. Next slide. PFS as per investigator, all subgroups got again benefit with this combination. Next slide. PFS2 and interim analysis of OS, and it's yet to get mature. They were immature, so we can't really comment on it. But likely, as per the previous PFS and also the recent update of the OS, I mean, we all expect there to be going to be a very good OS benefit with this combination. Next slide. So safety summary, again, except the additional chemotherapy, there is really not significant side effects by combining osimertinib with the chemotherapy. And all do say like a lot of side effects, but like practically when I implemented, I didn't see significant side effects with combination. Next slide. Mariposa study is a very interesting study. So in this one, documented EGFR exon 19 and exon 21 mutation, and the patient got randomized to amivantamab plus lazertinib versus osimertinib versus lazertinib. So lazertinib monotherapy arm was included to assess the contribution of the component. So what osimertinib do, we know really, but lazertinib, is it really going to contribute as a single agent or not is a question. The primary endpoint is again PFS. Next slide. So these are the baseline characteristics which got really very well balanced across all the groups. Next slide. Lazertinib monotherapy demonstrates meaningful clinical activity. That's 18.5 months, and it's almost, I mean, slightly superior or equivalent to osimertinib. Amivantamab plus lazertinib definitely scored really well. That's 23.7 months. And next slide. All subgroups got a very good PFS benefit. Next slide. The overall response rate and duration of response by BSR is significantly better with amivantamab plus lazertinib. So if you see, the CRs also significantly noted in this group compared to osimertinib. That's 29 versus 15, that's 7% versus 4%. And PR also 79% versus 81%. But if you see the curves, they're starkly separated. That is across the, it's also there, again, the initial separation got noted. So maybe in future, we use amivantamab plus lazertinib alone. Next slide. Interim overall survival, again, at 24 months, 74% versus 69%. The hazard ratio is only 0.80, but still it's significant. And the follow-up, if you see, it's only 24 months. Maybe in the long term, we do see more data regarding this. Next slide. Adverse events to discontinue the treatment of all agents occur 10% of patients in the combination versus 3%. It's slightly higher, but still adverse events leading to death, it's 8% versus 7%. It's almost equivalent. Next slide. So the conclusion, for the first time in the evaluation of EGFR TKS, osimertinib translate PFS to significant OS benefit. Osimertinib has a median PFS of 18.9 months and median OS of 30.6 months, which is significantly higher compared to the first and second generation TKS. Osimertinib has shown efficacy in patients with CNS metastasis. Fewer CNS progression events were observed, and fewer and lesser severe adverse events gives osimertinib better safety profile. It's a new standard of care in the first line, and in future the combination is going to be the standard. And amivantamab plus lazertinib in patients who are really affordable, we can offer. Next slide. With this, I conclude this session. Thank you so much, Stalin, sir, for all the orders for this opportunity.
Yeah, thank you. Thank you for such an extensive talk on the first line management of EGFR mutated metastatic NSCLC. So everything has been discussed with an overview of lung cancer by Dr. Venkatesh, and followed by the role of tissue and liquid biopsy by Dr. Venkata Simha, and the treating an EGFR mutated NSCLC by Dr. Kripa. So we are way past our time. So I will just keep this panel discussion short and discuss only the valid points and what we are routinely doing for our EGFR mutated metastatic non-small cell lung carcinoma patients. So I would like to invite my panelists, Dr. Mahati, Dr. Hanisha, Dr. Aditya, Dr. Venkatesh, Dr. Kripa, and Dr. Shravan Kumar. Hope all are there. Am I right?
Yes, sir.
Yes, sir.
Okay. Thank you. Hope my screen is visible and I am clearly audible. Okay. So this is the case which was provided by AstraZeneca. So a 64-year-old gentleman, so presented with coughing, progressive breathlessness, and severe backache. He could not walk without support in the last 10 days with giddiness since 5 to 6 days and a weight loss of 5 kg. And he is a non-smoker. A PET CT scan was done. A mass lesion in the right upper lobe was there with hilar nodes and multiple bone metastasis. And the biopsy was done, which was adenocarcinoma. And on molecular analysis, it is an EGFR exon 19 mutation, which was positive. So, my panelist, Dr. Kripa. So, how common is EGFR mutation in your practice? So, what is the exact percentage in your experience of getting an EGFR mutation positive? Dr. Kripa? Dr. Hanisha?
Sir, it is about 40%.
So it is 40% in your practice. Okay. So Dr. Aditya?
So out of every 10, I think 2 to 3 people are EGFR positive.
Okay. I can't get how much percentage?
Sir, around 20 to 30.
20 to 30. Okay, fine. So Dr. Mahati?
Yeah, around 30%, sir.
Yeah, so on an average, it will be around 30 to 40%. So of EGFR positivity, possibly. So 1 out of 3 lung cancer patients we see in day in and out will be EGFR mutation positive. That's why this much of discussion happening in the EGFR and the development of newer therapies, and especially these patients will be having brain metastasis and the drugs which we are developed, which can cross the blood-brain barrier and target the brain metastasis. And this case has multiple ring-enhancing lesions in the cerebellum and cerebral hemisphere with significant perilesional vasogenic edema. So this is the final diagnosis, stage 4 NSCLC with exon 19 deletion with bone and brain metastasis. So coming to Dr. I will ask this question to all panelists. We have not discussed much about the Venkata Simha's presentation. So I will be asking all. Dr. Shravan, so how often, so what is the way you diagnose a lung cancer? It is a majority of time tissue biopsy. So how often you send both tissue and liquid biopsy at diagnosis for the analysis of mutations? Do you practice that routinely?
No, sir, not both together. Only if there are no financial constraints, I'll ask for both of them, or else most of the time it is tissue.
So other panelists, any difference of opinion? I do only saw a tissue biopsy. So and I send the tissue for unless the patient, unless the primary tissue is exhausted and patient is not willing for a rebiopsy, I will send the liquid biopsy for them. And I don't typically send. Majority of my patients are not affordable to get both tests done. So I don't typically do the solid and liquid at the same time in a patient at diagnosis. I do solid tissue and the biopsy from the tissue and the mutation analysis from the tissue. So any difference, anyone routinely practices doing both solid and liquid biopsy diagnosis for the mutation analysis?
No, sir,
Agree
not
with
from my
you.
point of. Yeah, please carry on, doctor.
Hello?
Sir,
Yeah, go
so
ahead.
both as such, I too don't do, sir. But my last 2 liquid biopsies of the patients who one patient had a tissue biopsy but inadequate for molecular testing. So for them, he's not willing for the repeat biopsy. So I have sent for liquid biopsy and luckily it has come positive. And other patient is not feasible for biopsy. So there is only 2 patients which you have sent in the last 1 month, sir. So
Yeah,
both
majority of the times we do the same. So preferably we get a tissue biopsy, and if it is feasible, we do mutation analysis on the tissue. Otherwise, we'll go ahead with doing a liquid biopsy. So although the data is robust and says that if you do both, the chance of picking of mutations is high. So there will be much logistic issues in the routine clinical practice. The data is different and our routine clinical practice is different. So it is very financially stressful for the patient, and also logistically not possible many of the times to do both at the time of diagnosis. But preferably, so if you do both data wise, the chance of picking up a mutation, because it negates the tumor heterogeneity, so the chance of picking up mutation is higher than doing either alone. So coming to this case proper, so this is a stage 4 non-small cell lung adenocarcinoma with exon 19 deletion with bone and brain metastasis, a typical common case we see in our routine practice. So Dr. Mahati, how you do deal with such cases? Dr. Mahati? Dr. Hanisha?
Yes, sir. If the patient is affordable, I would like to offer Osimertinib, given the data of FLORA, given the CNS PFS benefit. So I would like to offer the patient Osimertinib along with denosumab if the patient is affordable for bone metastasis. If painful and impending fracture is there, then I would like to offer radiotherapy also for the bone metastasis. And if it is solitary brain metastasis, then initially I would like to go ahead with radiotherapy also, symptomatic brain metastasis.
So this is multiple ring enhancing lesions in cerebellum and cerebral hemisphere with significant perilesional vasogenic edema. So for this case, what are you going to do?
Then I would like to offer, if the patient is symptomatic, then whole brain radiation, short course whole brain radiation, followed by
Aditya?
osmo.
Okay. Dr. Aditya?
Yes, sir. Actually, I would like to go with radiation first, along with corticosteroids. So once the patient then stabilizes, then we can start with systemic therapy. Patient is affordable, then go for osimertinib directly. And regarding the bone, and if any significant pain in the bone lesion that can be targeted, so in the same sitting, we can do palliative RT to the bone lesions, and then we can add zoledronic acid.
Dr. Kripa, are you there? Dr. Kripa?
Ma'am, you will have to unmute yourself.
Hello, Dr. Kripa? Not there? Okay. Dr. Shravan?
As the patient is symptomatic, I would like to give this is for the whole brain RT, followed by systemic therapy with both osimertinib and chemotherapy, given better PFS in CNS Mets, almost 10 months advantage with osimertinib and chemo.
Okay, so I do the same. So if the patient is symptomatic, ideally the whole brain RT followed by the EGFR TKS. So this is the evaluation of the EGFR TKS right from IPAS to the FLARA. So when I was doing my residency, then Geftinib was the standard of care and it is the most widely available molecule. And the median progression-free survival the patient gets with the Geftinib was 9.5 months. So which slowly progressed over by time the FLARA results came, it is 18.9 months. And this is the CNS penetration of osimertinib. So of the molecules available, this osimertinib is the molecule with highest achieving the brain concentrations and the ratio of brain and plasma concentration, and significantly crosses the blood-brain barrier and can even, this is with the radio labeled ligand that the showing that the osimertinib can penetrate the blood-brain barrier and enter the concentrations in the brain to a significant level and achieves a good volume of distribution in the brain. And this is how we treat an EGFR mutation patients who had brain metastasis, preferably if the patient is symptomatic. So we go for local therapy, either a radiotherapy or, so if it is a solitary lesion, stereotactic radiosurgery. If no, the brain metastases are not symptomatic, osimertinib will take care of the disease. And Dr. Kripa has in detail discussed about the FLARA outcomes, and these are the FLARA trial and the brain outcomes. Even in patients with brain metastasis or without brain metastasis, this is the drug which has done superb. And even in the patients with brain metastasis, the median progression-free survival is 15.2 months, which were never heard in the management of metastatic NSCLC prior to this. Next, these are the brain outcomes. So it is way superior over afatinib and dacometinib combined, compared. And this is the treatment given to this patient. So palliative radiotherapy to the spine and to the brain, and patient was started on osimertinib. So to all my panelists, so Dr. Aditya, so have you ever used chemotherapy plus EGFR TK, either Geftinib or the osimertinib?
No, Dr. Sal. Actually, I've never used chemo with TKI. Till now, I've used only TK, either TKI or chemotherapy.
So, Dr. Hanisha, your experience of using a chemotherapy, actually, Dr. Kripa has shown the FLAURA2 results and shown that it provides an excellent survival compared to the TKI alone. So, your thoughts and your experience of using an chemo plus EGFR TKI combination
I've used
frontline and
first generation EGFR TKI, sir, with chemotherapy in very young patients, but I haven't used osimertinib with, I haven't started using FLAURA2 regimen as of now with osimertinib. Yes.
Dr. Mahati, so is she there?
Yeah. Yes, sir. Most of the patients are not affordable for osimertinib, so I tend to, if they are fit patients, I tend to use Geftinib plus chemo first line.
Dr. Shravan?
Only one patients are currently ongoing. Patient brought me the Flora 2 paper and gave me the paper to treat him with Osimertinib and chemo.
Dr. Venkatesh?
So,
Jeffney plus chemo is what we give for all most of the general patients in TMH Bombay exclusively, mostly. But Osimertinib plus chemo, so far I never did, sir. But Jeffney plus chemo, we have vast experience, sir. Jeffney plus chemo combination.
Yeah. This case, this is the follow-up PET CT scan in March 21. So there was a good response, and this is the effectiveness of TKIs in brain metastasis. So Osimertinib provides a good overall response rates and CNS disease control rates, and the duration of the median duration of CNS response was not reached compared to the first generation TKIs. This is the follow-up brain MRI brain. There was a complete resolution of the brain metastasis, and no additional intervention was record. And even the real world evidence of case reports had shown that there will be excellent responses to the brain metastasis and excellent clinical improvement and the lesion improvement with the use of Osimertinib in metastatic NSCLC with brain metastasis. These are the real world evidence case reports. So almost a complete response with the use of Osimertinib in these cases. So the key points are radiotherapy for brain is not needed, and this still patient had complete resolution of brain metastasis, almost complete resolution of the primary disease also. And we often see with EGFR TKIs and the ALK TKIs that these patients will have an excellent responses with the EGFR TKIs, and the patient will have complete resolutions, unless like chemotherapy, where we see majority of the responses are the partial responses. And this patient remains progression free even after 19 months after initiating the Osimertinib. Excellent response to Osimertinib, and thank you. And recently I came across a case of Osimertinib where after 5 days of Osimertinib, actually the patient's breathlessness have increased. So this is a case of adenocarcinoma lung. She received palliative radiotherapy to the bone, and I started an empirical Jeftinib even before the EGFR report. So because my experience of Nizam suggests that, so I had presented a paper in ESMO Asia. If you have a female, if you have a non-smoker, the chance of EGFR mutation is 66%. So that is, you are right 2 out of 3 times that if at all you have a female, especially non-smoker. So if she is not willing for chemotherapy, I typically, if the patient is symptomatic, and I will start with an empirical Jeftinib and wait for the report. So I started an empirical Jeftinib. She improved significantly well, and she became completely breathlessness free, able to do her activities of daily living. When the report came as EGFR exon 921 L858R, I switched her over to Osimertinib. But after 5 days, there was significant increase in breathlessness, and patient has almost onto the oxygen. So I don't know whether the Osimertinib caused interstitial lung disease, so or it's a viral counterpart which has occurred at the same point of time. I didn't have any reason. So I started her on steroids. She again, within a span of 7 days, she's off oxygen. She is doing good. I restarted Osimertinib. She completed 1 month. She is doing excellent. So anyone has encountered such a complication with Osimertinib or any of the EGFR TKs? This is the first time I'm encountering such a complication. Just a personal case to discuss, which happened in few days back.
no, sir.
Any thoughts? Interstitial lung disease has been reported with the EGFR TKs, but after 4 to 5 days of Osimertinib, I didn't expect it to happen. But you should be vigilant that
Most
but
probably,
after
as you said, it is somewhere like viral pneumonitis or something. Secondary bacterial infections are mostly at the point of
possible, possibly.
because the interstitial pneumonitis with 5 days or
Usually it happens over a
2 weeks
period
of
of time.
therapy.
Yeah,
You cannot expect that interstitial pneumonitis, no?
But she improved significantly with steroids. But okay, so that's good luck. Okay, so this is, thank you all my panelists for
I just want to
wonderful
ask one
discussions.
question to you, sir.
Yeah.
At this point, so what are the factors you are considering for taking FLARA-2 trial? Any patients you started this Osimertinib plus chemotherapy?
I didn't use Osimertinib plus chemotherapy enough NM of patient, but if a patient is young, so practically speaking, the case I have discussed just now, she is a 65-year-old lady. So I have started on Osimertinib. I didn't usually do both at the same time, and I don't impair the quality of life. So typically I do in a sequential manner. So I counsel the patient in such a way that I will start osimertinib, see if your breathlessness, everything improves. So I will slowly start chemotherapy to you. So this was the way I counseled her. But if any young patient is there, definitely I do chemo plus osimertinib because the FLAURA2 data is very good. So, but doing osimertinib alone is not wrong. Definitely not wrong. So you can always sequence therapies. For the same patient I discussed, now I counseled for doing a chemo plus this thing, but after 5 days, once she is on oxygen, so I'm not spectacle in doing chemotherapy now. So I will be doing a sequencing of therapy. But if a patient is young, able to tolerate, definitely you can counsel regarding the FLAURA2 data and do the, because especially in the patients who had a brain metastasis, chemo plus osimertinib combination the data was good. So we are behind our schedule. So I invite Dr. Rachana for her next talk, the selecting therapy for less common driver mutations in advanced NSCLC, MET, ALK, ROS, and NTRK. So Dr. Rachana Chennamaneni is Associate Professor in the Department of Medical Oncology, NIMS, Hyderabad. So over to you, Rachana.
Good evening,
Rachana?
sir.
Good evening.
Yes, sir. Can you hear me?
Yeah, Rachana, go ahead.
Can I share my screen? Is my screen visible?
Yes, ma'am.
The PPT is visible, right? Can anyone please let me know if this PPT is visible?
Yes, ma'am. The PPT is visible. There's a black box, ma'am. If you could just hide that.
You can minimize it.
Now it's okay?
Yes,
Yeah,
ma'am.
it's okay now.
Yeah, now it's fine. Okay, yeah. Thank you, Stalin sir, for giving this opportunity, and thank you, AstraZeneca, for the slide. So I will be discussing about the other driver mutations other than EGFR, which has been discussed till now. So I will be briefly going through the MET, ALK, and NTRK mutations. So this would be the content I would be discussing. So these all things have been already discussed in the diagnosis of lung cancer, starting from the histology and now moving on to the molecular diagnostics with various markers. So this is a 2017 treatment options for advanced lung cancer. So initially it was only with RAS, ALK, EGFR, and later on we had the immunotherapy drugs. But this is not as simple as we see it now. 2024, the landscape has completely changed with multiple targets and various options also. And new drugs for this old targets also. We have got very new drugs for the ALK fusion or the RAS1 mutations. So let's see what are the drugs. And these are the testing methodologies which are also been discussed prior. The EGFR testing by PCR-based methods, ROS1 by FISH or IHC, and PDL1 by IHC again. So if we, other than EGFR, the other common mutations, the minimum panel should include at least ALK and ROS1. EGFR, ALK, and ROS1 are the basic tests which we need to do for all the NSCLC patients, especially the adenocarcinomas. And extended panel should include your BRAF, RET, HER2, KRAS, and MET amplifications also. So this is the testings. We can either do a single gene testing, the reflex testing, or we can do multiple genes at a time. But mostly all the clinicians prefer a multiple gene testing because of the tissue or scarcity. We generally have a very small tissue from the biopsies of lung tumors, and this tissue cannot be used for a reflex testing by each methodology. So doing a NGS at a time for multiple genes would be more helpful in identifying the targets. So the increasing in the genomic profiling, we are able to identify various molecular complexities of NSCLC, and we are able to develop new molecules and try new molecules to target these genomic alterations, so that the benefit for the patients would be increased by targeted therapies and minimizing the toxicities. And one thing is, just based on the PDL1 report, without getting the molecular analysis, it's better not to start an immunotherapy. Wait for the molecular analysis. If the patient is symptomatic, we can still start chemotherapy, but immunotherapy preferably to start after you get your driver mutation testing only, because immunotherapy is found to be not effective in patients who have a driver mutation positive. And the landscape for the targeted therapies always starts from the second or third line in the metastatic setting, then moving on into the metastatic first line setting, and finally coming into the localized or the early disease setting, like how we have seen with Osimertinib, starting from the second line, then coming to the first and now in the adjuvant setting. Similar for all the targeted therapies, started from the metastatic and coming to the adjuvant therapies. So these are the approved FDA-approved therapies. Now we have for the EGFR, we have for the exon 20 insertions also. We have for ALK, ROS1, BRAF, NTRK, RET mutations, metexon 14. We have approval for the KRAS G12C mutations. And we have a tumor agonistic markers for the HER2 with the trastuzumab deruxtecan. So these are the current molecular targets and the various drugs which are available to target these, such as the ALK inhibitors, the EGFR inhibitors, and various new drugs are being developed for the AKT-mTOR pathway also. If we see the response rates by various targeted therapies based on the targets, these are the different targets. Like we can see that patients who have a ROS1 mutation, they do respond very well to the targeted therapies with a very good progression-free survival. But if we see the RET mutation, which is lower down, the response, though we have targets, the response is not as high as we expect with the ROS1 or ALK targeted therapies. So even though we have some targeted therapies, the response or the progression-free survival may not be as good as we expect, as we see in the ALK positive patients or the ROS1 patients. So yes, we do have drugs approved, but all targeted therapies do not give you the same progression-free survival or the same response rates. It depends on the molecular target. So next, moving on to the ALK rearrangement, which is the second most common driver mutation after EGFR. The prevalence varies actually. In females, on the non-smokers, similar to EGFR, we have higher incidence. From our institute, we have an incidence of around 6 to 7% for ALK positivity. Overall, India, the prevalence is expected to be around 3%. And it is usually mutually exclusive, but we do see some cases where we have co-mutations of EGFR plus ALK genes also. And predominantly it is seen in the adenocarcinomas. And the best way to test for ALK is IHC. I wouldn't say the best way, but it would be the easiest way and the fastest way to identify an ALK mutation. And various studies have found a very good concordance between IHC and the FISH testing, around 93 to 100% sensitivity with IHC compared to FISH. And if the IHC is positive, we don't need to reconfirm it by doing a FISH, like how we do for ROS1 testing. So PCR can also be done to identify ALK, but it would be limited only to the predefined fusion partners. ALK usually has multiple fusion partners. So by doing PCR, we'll be limited in our capacity to identify all the fusion partners of ALK. Or we can also do the NGS testing, which can identify all the different mutations or the fusion partners of ALK. So the first drug which was studied for ALK mutation, Crizotinib, it was a dual selective inhibitor for both ALK and c-Met, and it is found to inhibit the cell growth. So initial studies have shown that patients are responding well to Crizotinib who have an ALK mutation positivity. This was the first studies which have shown some good responses and better progression-free survival with the usage of Crizotinib. And the common adverse events which were known to occur or identified with Crizotinib were the visual disturbances like floaters, flashing lights. A rare side effect for other TKIs, but for Crizotinib, yes, visual disturbances are one of the common side effects which patients do complain of. And the Crizotinib has also resulted in a better overall survival compared to the standard therapy, which was chemotherapy at that point of time when Crizotinib was analyzed. And these are the conclusions for the Crizotinib trials. The initial trials for ALK inhibitors, and they say that ALK was a new molecular subset of NSCLC. Crizotinib resulted in a 6-month PFS of 72% and response rates of nearly 60%. And clinical trials are ongoing, and now we know the results of these ongoing trials, which have led to a significant improvement in the survivals of ALK positive patients. So at present, these are all the ALK inhibitors which we have, the first generation Crizotinib. Then moving on to the second generation drugs, the drugs which are available for us in India are Alectinib, Ceritinib, and the third generation Lorlatinib. The rest of the ALK inhibitors are presently not available. And moving on to the second and third generation ALK inhibitors, Crizotinib has changed the treatment paradigm for ALK positive NSCLCs, whereas Alectinib and Lorlatinib have taken it to a newer places. So the survivals which were not expected for any metastatic tumors were achieved with the usage of Alectinib and Lorlatinib both. So in the ALEX trial, we can see that alectinib has improved significantly the progression-free survival and overall survival compared to crizotinib. And this improvement was also seen in patients with a measurable CNS disease who had a baseline metastasis and also those without a baseline metastasis. If you can see in all the 4 Kaplan-Meier curves, the curves are widely separated with a significant benefit for alectinib compared to crizotinib, and the hazard ratio for PFS was around 0.4. Coming to the CROWN study, lorlatinib, and the update is going to be presented in the coming ASCO. So lorlatinib has also significantly improved the progression-free survival compared to crizotinib with a very significant hazard ratio of 0.28, which is not a common hazard ratio which we see in the metastatic setting. And the efficacy is also seen in patients who have a baseline brain metastasis. And these drugs are also been tried as ROS1 inhibitors because they also target the ROS1. Crizotinib in the PROFILE trial, which has shown a good response rates and a median progression-free survival of 19.3 months. So moving on to the next target, that is the MET. MET is a common mechanism for resistance for EGFR TKIs. Generally, when a patient progresses on either gefitinib or osimertinib, we do ask for a repeat biopsy or liquid biopsy and do the molecular testing. One of the common resistance mechanisms for EGFR is a MET mutation. And this can also occur upfront, not only as a resistance mechanism, but it can be seen upfront. And one of the common targeted mutation is the MET exon 14 mutation. So initially, crizotinib was the drug which was tried as a MET inhibitor, and following that, various other drugs were also tried like cabozantinib and glisatinib. But presently, the drugs which we are targeting for MET are crizotinib, tepotinib, and capmatinib. If you see the response rates are good with tepotinib and capmatinib around 40%, and median progression-free survival of 8.5 months with tepotinib. And for patients who are not received any first-line therapies, capmatinib has shown a PFS of 12.4 months. And capmatinib and tepotinib have the FDA approval for usage in the MET positive NSCLCs. Then we have the NTRK, that is the neurotrophic tropomyosin receptor kinase. This mutation is seen in various tumors, and so the trials have also included multiple primary tumors to analyze the effect of the NTRK inhibitors, and these are the basket trials. We have larotrectinib and entrectinib, which target the TRK ABC, and they also have effect on the ALK and ROS1. And larotrectinib and entrectinib both have been approved for the usage as NTRK inhibitors. And the extended generation TRK inhibitors are the selitrectinib and repotrectinib. These are also found to be effective against the NTRK. So if you see the progression-free survival with entrectinib, it is around 11.2 months for patients with NSCLC. The other mutation is the RET gene. This RET gene does not directly bind to its ligand, but it requires a co-receptor to act, and it usually uses the glial cell line-defined neurotrophic factor. And similar to ALK and ROS1 positive tumors, durable benefits have been seen for RET inhibitors with pemetrexed-based chemotherapy. And various drugs, multi-kinase inhibitors have been tried, such as vandetanib, cabozantinib, lenvatinib, and alectinib. These were initially used for the treatment of RET positive NSCLCs. So the drugs which are found to be active against RET mutation are vandetanib, cabozantinib. Then we have the alectinib. We also have selpercatinib and pralsetinib. These are the drugs. Pralsetinib and selpercatinib are the approved drugs for RET mutation positive NSCLCs. So these are the mutations which have an FDA approval, and these are the various other targets which are seen in NSCLC. When we do a limited NGS panel, we are restricting ourselves to 12 genes only. But if we go for the full NGS panel, we find out various other mutations. And yes, there are various trials going on to identify targeted therapies for these mutations also. So as the genomic landscape is expanding, the targeted therapies are also increasing, the survivals are increasing. Quality of life is better for the patients with the targeted therapies compared to chemotherapy. And NSCLC survivals have drastically improved from 6 to 8 months with just chemotherapy alone to now for 5 to 6 years also for many patients with the genetic alterations. So thank you.
Thank you, Rachana. Thank you for such an extensive talk covering all aspects of other drivers other than EGFR mutated NSCLC. So we came to the end of the session. So the last 1.5 hours, we had a very good discussion on various aspects of the lung cancer. So with a nice talk of overview of lung cancer by Dr. Venkatesh, and on liquid and tissue biopsy by Dr. Venkata Simha, and managing the EGFR NSCLC by Dr. Kripa. So we had a case discussion and inputs from our experienced panelists and other drivers by treating testing of other driver mutations by Dr. Rachana. So thank you AstraZeneca for this opportunity, and thank you Kavina Creations for making an uninterrupted platform and organizing this meeting. Thank you.